Welcome to this special webinar of the Maharashtra Ophthalmology Society. This time, the scientific committee has got a very wonderful topic, the FAQs intravitreal injections, which, when, and how. Now, this is very, very pertinent because earlier intravitreal injections were only by a select few and were also for a selected few patients. But soon, perhaps we may have a time when ophthalmologists will be doing more intravitreal injections than they do cataract surgeries. And it's no more a prerogative just for vitreoretinal surgeons. So Professor Agini Parikh ma'am and Dr. Swapnesh and the entire scientific committee team have got 4 expert panelists, Dr. Prashant Bawankure, past president MOS, Dr. Manoj Saswade, one of the first vitreoretinal surgeons in Marathwada, again like Dr. Prashant, an alumnus of Shankar Nethralaya, Dr. Ashish Vaidya, a senior VIA surgeon from Mumbai, and Dr. Preetam Samant, whom we all know, President BOA, and of course, again, President, Chairperson, Scientific Committee of MOS. And I think I would like to add that Dr. Swapnesh always makes this as if it is a Shankar Nethralaya alumnus affair, because all of them are SN alumni. And we have Dr. Manish and Dr. Swapnesh as the hosts. I would hand this over to Professor Agini Parikh, the Chairperson, Scientific Committee, who has been the guiding spirit behind all this.
Thank you, Dr. Parikshit Gupte, sir. And, we started this year with a lot of webinars. Some districts are still remaining, but, they were having this flood situation. So, and, when we were doing the conference, all of us were, very keen that, we should have something different, something new. And instead of the didactic talks, and, now surgeons are very busy with COVID and preparing presentations, and also Swapnesh came up with these ideas that we need to clarify some doubts and with the experts. And let me tell you that this is looking like an SN alumni, but, it has just happened unconsciously, and I don't think Swapnesh is to blame for it because, as usual, we are always in a rush to say that, okay, what next? Tuesday mornings, that please let's put everything together. And these are really the experts, and we are I think they are proud. So Swapnesh is, now since you said this SN alumni, from this Sunday we are starting a Gurukul under the aegis of the Bombay Ophthalmic Association, which is again, this Swapnesh's idea, where so every institute will have once a month CMEs, but it will be by the institute faculty, by the current faculty or the alumni. So I think you've introduced everybody. We have a great lineup of hosts, Manish and Swapnesh, our own committee members, and experts, Preetam, Prashant Bawankule, both have been scientific committee chairman of the MOS, and Ashish. And so let's, and Manoj Sasavade, like you rightly said, that when we used to have our patients coming from Marathwada, we used to always ask to follow with him because that time he was the only one.
Thank you very much.
And a lovely team of Swapnesh, Sirish, Pankaj, who put everything together, and the entourage people who are always there to support us. So I seem to be taking a lot of the retina time, of which I don't know much. So over to Manish and Swapnesh, and thank you, Parikshit Bhai, for being you and the ever-supporting president.
Good evening, everybody. Thank you, madam, for opening remarks.
A general medico-legal aspect about intravitreal injections, do's and don'ts, and obviously we are going to touch upon the clinical aspect also. We are going to leave out the end-off related intravitreal injections for now, because then that's beyond the purview of this time frame. So let's begin, and one by one the panelists can give their own opinion and add to what the previous speaker has told. So let's address the elephant in the room, that we know that all of us have been using off-label drugs like Avastin and Zaltrap. So what's the medico-legal implication of using these drugs, and also the other lesser-known bevacizumab from companies which I won't be naming here, but not commonly used. bevacizumabs. So over to Preetham sir, and Manish sir, you can also chip in.
So a few years back, about 4 or 5 years back, there was a situation where there was a cluster.
Yeah, no problem.
Yeah. So a few years back, all of us remember that about 4 or 5 years back, there was a cluster endophthalmitis in one of the hospitals in Gujarat, and after that, DGCI had put a blanket ban on use of Avastin in ophthalmology, and that was a time where there were a lot of deliberations between VRSI and DGCI, and they gave conditional approval for use in ophthalmology. I think it is an important thing that before we give injections, Avastin, which is most commonly given injection, that we know what we are getting into and what are the possible legal implications. So, Dr. Preetham, I think, can you start with your...
Yeah, can you hear me?
Yes, yes.
Yes, sir, we can hear you.
So, I want permission for about 60 seconds or 2 minutes to first get to the question. Can I get that permission?
Yeah, sure. Please go ahead.
Okay. So first of all, I would like to pay my respects to the President, Dr. Parikshit Gokde, our scientific chairman, Dr. Ragini Parekh, madam, to Manish and Swapnesh for coming up with this fantastic webinar. And also my respects to my seniors, Dr. Manoj Sasode, Dr. Ashish, Dr. Prashant Bawankole. They've always been there for all the retinal surgeons in Maharashtra. So hats off to them. Last month on the list, my respects to NTOD. Of course, I missed out Dr. Pankaj Shah. So my respects to him and NTOD. And I can see Atharva there. He's enthusiastic. He's an entrepreneur. So my respects to him. So with that, what I'm going to say is, let's be candid today. I remember a movie which I had seen a couple of years ago called Split Wide Open, starring Rahul Bose. So I'm going to split wide open my preferred practice patterns. We hear a lot of evidence-based medicine, but we have to combine evidence-based with practice-based medicine in the real world. So I'm going to speak about my experience. And I think the first question which you've asked, which is on the screen, is what is the medico-legal status of Avastin, Zaltrap, and other lesser-known bevacizumab? So let's understand that these are not FDA approved still for the diseases that we use them in. But having said that, we know that so is vancomycin, so is amphotericin, so is ceftazidime, but we still use them in endophthalmitis. So when there is a lot of evidence-based literature with us, then I think it is safe. We are in a safe zone to use drugs like Avastin and Zaltrap in the diseases where they are not FDA approved, like diabetic macular edema, wet AMD, central retinal vein occlusion. So I am using these medicines, these drugs in these particular conditions. I use Avastin, I use Zaltrap. I am also using the biosimilar form of Avastin in certain patients who are economically challenged. But when I do that, I take a exclusive consent where the patient is aware of the fact that we are using a drug which is not FDA approved, but which has sufficient evidence in literature. So this is my practice. I hand over the mic to the other colleagues.
Yes. Am I audible?
Yes, sir.
Yeah, Manoj.
Yes. The thing is that Avastin, why we are using, despite of so many conspiracies and controversies and even the medical legal threat, this is just all vitreoretinal surgeons want to help the patients, poor patient, needy patients who require monthly injections, and that are other brands are very costly. That's why we take a risk. Who is taking the questions comes medical legal aspects. Now, Preetham sir has correctly pointed out, whatever we are doing, we should have evidence. If anything is there, evidence-based, whatever will happen in CPA, they will see the evidence. They will see the references. There are numerous number of references and evidences in favor of Avastin. So you can easily win the case if it is said to be an off-label drug you have used. That's why nothing to worry. As far as it is not FDA approved, it is only allowed by the DGCI under certain conditions that you should purchase from an authentic dealer. You should keep the record of batch, date of purchase, and prepare the drug properly under the laminar airflow allocate it properly, use it within a stipulated time, as well as if something happens, you should immediately inform. And one more thing is that you should do the culture of the first dose before giving to the patient. And these are the guidelines. If you are following them, then there is hardly anything to worry. You can prove in any court of law that this, whatever it is done, it is authentic, even though it is off label. That's why my point.
Sir, all these
Hi,
points
can
are
I
well
speak?
taken. Yes, sir. Vaidya, sir, please go
Yeah,
ahead.
can you hear me? Yeah, okay.
Yes.
See, as far as Avastin is concerned, I think the DGCI has sort of semi-approved it after the Gujarat
Yes,
episode.
yes.
But as far as Zaltrap and the other bevacizumabs are concerned, I don't think there is any definite evidence for the DGCI to approve it as of date.
Yes.
Because I do remember in one of the recent webinars, Professor Atul Kumar has specifically brought out this point and said that Avastin has been approved, but Zaltrap has not been approved.
Not yet.
So I think if for Zaltrap, you are in a little, worse territory than you are giving Avastin. That's my take on it.
So I'd just like to add that on vial of Zaltrap, it is specifically mentioned that it is not for ophthalmic use. That has been written on the vial. So I think we should be aware before when we are using Zaltrap, because that directly puts us, you are using a drug which is not allowed in the eye.
Yeah, there are 2 points in favor of us. One is the evidence base, as Pritam sir said, and second, he also mentioned about the consent. If both the things are there, I think they should stand in the court of law.
May
Yeah,
Yeah,
Manish.
Dr. Prashant has.
Yeah, I think we need to understand, as Manoj has very clearly said, that it is our sentiments for the patient that really force us to use a cheaper options. Anyone would have loved to use the costliest and approved options. But at the same time, as Manoj said, I would like to differ from him that it is not the evidence, it is sometimes the sentiments, or that day, how is the mood of a judge, he will take care. You understand, he will give a verdict, because there has been a verdict against Avastin in spite of having what I should say, a ruling from VRSI as well as DGCI that it can be used against one of our colleagues from Hyderabad. So what we need to understand it, at least a DGCI permission for Avastin and biosimilars which have got permission, better use it, because in court of law, the law is really blind. Whatever evidence you suggest, even the written consent has no technical value, but for I should say a piece of paper.
One more thing, sir, I would like to add that in court of law, when they look at evidence, they look at textbooks and they do not look at the journals.
Yeah.
So we have to. That is something everyone should be aware of as far as the the medical legal status of these off-label drugs is concerned. Avastin has been well documented in a lot of textbooks by now, but I think Zaltrap puts us in sticky wicket on that.
Sir, taking a consent about Zaltrap, so what is the importance of that then? If we say that Zaltrap on the bottle itself, we don't have enough literature review, then people who are using Zaltrap would be thinking that because we have taken consent and the patient is made aware in his own language, we have taken signatures of the patient's relative also. When there is actual court case, then how does it stand? Because from evidence in a recent case 2 years back or 1 year back, a colleague in Bangalore from a retina center, he had to pay a huge sum of money for an end of related to Avastin. And sadly, because of the pressure of all this, in fact, the colleague had to lose his life. And that's a known case in front of our eyes, which had come into the newspaper with the name of the surgeon also. So when we say that we are taking consent, then how much does it help us, especially in the case of Zaltrap, where the peer reviews are not there, not much not much publications. And Sasaude sir told that taking the injection, aliquoting under a laminar airflow, how many people actually are doing it and how many people are actually sending a culture for that? So as Preetham sir said that this is an open platform. So let's be honest and guide juniors like me, and also tell them actually what we are doing and are we doing the right thing by not following the actual VRSI guidelines.
Can I say, Sapnesh?
Yes, sir.
See, regarding this Zaltrap, you need to understand whenever you are using a molecule which has not much of a literature evidence, and unless it is approved as a research molecule by your ethic committee in your particular institute, then you might be spared in the eyes of law. But otherwise, you had it. So if you are in a big institute having a big banyan tree cover like you, umbrella for you, many things get really you can get away with it. Rather, I should say, if you have a ethical committee meeting saying that you are using it for a study purpose. But if it is not so, for people like us who are into individual practices, we need to understand we have to protect our skin first, whatever be our sentiments for the patients. I am also a person from a very economically backward zone of our state, from Vidarbha. So we do face this economic challenges, financial challenges of a patient. But please do follow only what BGCI has approved for our country at this point of time, because the law is really blind.
I think that's a takeaway point on this particular issue of what is the medical legal status of various drugs. I think that brings us to second topic as to we were just talking how many of us like to or how many of us pool the patients and give injections together, and how many of us give injections as they come, and what is a preferred strategy by the experts.
See, for me, I would begin this particular thing. What we have been following after the VRSI guidelines is that every patient, every vial of bevacizumab which it comes is which initially withdraw some amount of sample and send it for culture sensitivity, and only after we get a culture sensitivity that particular vial is used. We do not believe in aliquoting over here. We do a multipuncture technique, and that particular vial after I should say, once I puncture it for the sake of culture sensitivity, we use it for 10 days, because by the I send it on Friday, Monday I get the report. Some Monday to Saturday I use that particular wire. That's the way we do it at our center.
Okay. Dr. Ashish, sir.
Yes, I think the same way as what Prashant said, is that about 10 days is what we use the vial. And it sort of works out like, on day one, I would just do 1 or 2 patients, see that they are okay, rather than, because even pooling up patients, 10 patients together, and something is wrong with your vial, all 10 of them have had it. So it's better to do 1 or 2 patients first with the vial, wait and see, and then you do them on subsequent days, keep the vial for about 7 to 10 days. That's the way we do it.
Yeah. In my practice, that previously, before VRSI guidelines, I was doing the same way the Prashant sir was doing, multipuncture technique without culture. Okay, this vial used to last for 1 week because of the lots of load of the patients. It used to finish within a week. After guidelines, we have started doing the culture and then started using, but we have started making the allocating in the 1 ml syringe. Every 1 ml syringe packet, we used to ETO first, then use that, withdraw the drug with the 90 gauge needle with the filter, and again that packet and keep it. And it lasts for 15 days for us. And sometimes we forget to do the culture. That is, I should admit it honestly.
Okay.
But after first dose or second dose, we keep on following the patient. If something is clear, that itself says that the drug is safe to use.
Okay. Dr. Preetham, your take, please.
Yeah, so I'm a little different because, I know the VRSI guidelines ask us to culture the first before you start using the vial. But, I don't understand the basis really behind it, because you could be introducing infection in some of the injections which you're doing later on. So unless you're culturing before every injection that you give, then that's a scientific basis. That means every time you inject, you're assured that what is there in your vial is not infected. Then it makes sense. So I'll be very frank and candid that I have never cultured any injection, any vial of Avastin that I've given.
That's true. Good.
So we all remember that the Gujarat episode happened because the drug was probably spurious. So there used to be Kessler code, which is there, and there are not even retina surgeons are not aware. So do we still have Kessler code on the vial of Avastin, and can we use it still? Or is there any other method of knowing that this particular vial is not spurious? Dr. Preetham, sir?
Yeah, so the Kessler code is still there because, you know, and I leave it to my staff, because the moment the Avastin vial is purchased and it comes, you know, even before, when we receive it, you know, even before giving the sign, my staff just puts in the Kessler code and makes sure that it's a proper vial. Then it is received from the guy who's delivering it, and then the guy goes and gives the receipt, and it's done. So you don't have to wait for the day of the injection to ensure the Kessler code. The Kessler code is essentially of the product, right?
Yes,
So it can be done at that, it can be done at the time when the product is being delivered.
Right.
Okay.
So that is what is being followed at my place.
Yeah.
I will say that in our practice that we are having in-house pharmacy, so they know that who are the authentic people or the dealers of the Roche Pharma. So we get it directly from them, and that is authentic. They can't cheat the pharmacy. One thing. Second thing is that checking physically the vial, the cap of the vial, you should see that whether it rotates. If it rotates, means it is adulterated. If it won't rotate, that means it is directly from the factory. That is the simplest technique we are using.
Dr. Ashish, sir?
Yeah, same way we use the Kessler code. And but the most important thing is that giving a spurious Avastin is the responsibility of the government. The government cannot allow any spurious drug to be got. So I think, you know, if there is a spurious drug, it's a responsibility of the government and not of the patient or of the doctor.
I think
that will come later on.
Courts don't look at that, unfortunately, sir.
Unfortunately, that comes later on. Court comes later on. I have one episode because of the why we go for this one. 10 years back, Avastin I purchased because it gets a cheaper one. Distilled water at the cost of 18,000. Who will lose the money? The people have started selling and just sticking the cap of empty water, and I got trapped into that and suffered. There was no obviously court case, but the thing was that myself and my patient suffered.
Bapai sir, does all the do's and don'ts remain same for Zybev versus the Roche Avastin?
Well, personally, I have not used any other biosimilar of bevacizumab. I'm very scared of doing that because we are using off-label drug anyways. So using a biosimilar of that is, I think, little too risky for me. So yes. I have not really used it.
Preetham sir has some experience using Zybev.
Yeah, so I've been using Zybev, and you know, my audit shows that Zybev is as efficacious as the Roche Avastin and is as safe as the same.
Okay, good.
I would like the panel to guide the youngsters, because we know that a lot of these newcomers are traveling with the vials because they are a kind of freelance.
Swapnesh has lost his connection. Swapnesh, I think what he is saying is about the movement of the vial and the maintenance of cold chain while he's traveling between surgeon is traveling between the clinics. Advisability of doing that, and whether it is how would you do it properly? Can you take it?
I don't know. See, I doubt all four of us would have experience with that. So I don't think any four of us. That's my prediction. Maybe Sasode sir used to go to a lot of peripheries from Aurangabad, so maybe he has experience. But I don't have experience traveling with the drug in a cold chain. But I can just advise that yes, the cold chain has to be maintained between 2 to 8 degrees Celsius. If you're maintaining that cold chain, then you're safe, because at the end point where you're reaching, your protocols, if they are robust and you're maintaining a cold chain, then you're safe.
Yeah, I used to go everywhere, but the only thing that in my 12 years of the wandering, I never made a single patient as a guinea pig. Never intravitreal interventions, neither surgical nor injections. Patient has to come to our practice and get it done properly. Otherwise, the risk are to the heads of the VR surgeon only. Even if you are giving anywhere,
Exactly.
You are taking the things on your shoulder. For what? There is no reason why we should do this type of practices.
I would like to say what is happening is the youngsters are forced by the circumstances that every anti-segment surgeon is asking them to deliver at their own court or at their own OT. That is the truth, what they have to unfortunately go through. And because of the financial pressures which the youngsters have, they really are forced to do it. But here is a warning. Basically, one needs to understand intravitreal injection is we are breaching the ocular codes. So every chance of introducing an infection. Most importantly, if you look at the cold chain, what is cold chain? Can you really have an electric type of a cold chain maintaining a refrigerator like apparatus which you are carrying? No. What you do is you stack some cold packs into a insulated box, and that is how you carry. Trust me, you can never have 2 degrees for next 4-5 hours even. It cannot happen even if you stack it with total number of things, even if you carry a big box as big as 2 feet. So you cannot have absolute cold chain. So you are disturbing the cold chain first thing. Now comes the second question is, as very rightly said by Manoj, the onus of anything comes finally on an vitreoretinal surgeon. So remember, for that 2,000 rupees, because when you're injecting in someone else's premises, you have neither screened the patient adequately. You have neither, because you have a time limit within which you have to see your OPD. Then you also know the pathetic conditions of many a times the places which you visit are not really adequate or sterile enough to be injected. I sincerely feel, because I had also traveled so many places, I've seen the pathetic conditions of many of the places where I used to go. So, so it is not worth breaching that. And for money, yeah, I know it's a pressure, but if anything goes wrong, you will be on a fire. That's for sure.
One thing I would just in continuation with Prashant is that if cold chain is not maintained, what will happen? The potency of the drug will be at stake. But what about the infection? Infection, vitreous cavity is the world's best culture media. If you are not taking care of this one, obviously the onus will be on your shoulder.
Correct. I think looking at the everybody's response, if I can conclude the
Manish, I have one point.
Yes, sir. Sorry.
How does, see, we are talking of this cold chain maintenance. Now I want to extend it to a little bit further. How does your eccentrics, Ilia or Paginax come to you?
It comes in cold chain. They are properly maintained. Yes.
But one second. In cold chain, but how? It comes in a thermocol box, and in that thermocol box, they stack up the packs which are there, and they put the thing in. So I think the same way, if you are traveling for a short distance, the same way it can be done. Because when you get an eccentrics or Ilia, it doesn't come to you in a electronic or in a battery operated box or anything like that. It just comes to you in a thermocol pack with packets of ice in it.
Ashish,
packs of those cold chain packs.
Ashish, I think the message which will go is something different, which I agree with your points fully. But the transit time from a vendor to the
yes, that is what is the most important thing.
Yeah, that you need to point out here. It is not. We are traveling. What happens? Most of the vitreoretinal surgeons of a new genre, they have to travel to other outstations. They have to take a bus or take their own vehicle. It needs 2 to 3 hours. You travel there, and then you are not in a position to keep it again in a refrigerator. You hop from 2-3 stations over there, and that is what. So you do not get time even to put them back once you reach a particular destination into the refrigerator to get back those cool packs again to that level temperature, and that is what we mean by it.
Yes, definitely.
So
And
I'm going to add another angle to this. Now this is absolutely candid from my practice, that I have a lot of anterior segment surgeons who take Avastin from me. Okay, so I alicot it in a tuberculin syringe for them, and I keep it in a sterile pouch and I give it to them. Now, my standard instructions are it has to be used within 2 hours. Even if you're maintaining the cold chain, I tell them, please, because if they are going to store it for 1 or 2 or 3 days, then it's not good. I tell them that it should not be done. So many a times I have surgeons, ophthalmologists who are visiting NICUs, and they want to inject Avastin in retinopathy of ROP babies. In this situation also, I have clear-cut instructions that within 2 or 3 hours, 2 hours ideally from alicoating, the injection should be given.
Yeah,
So this
one
is
more
another,
to the
yeah.
in extension to you, that aliquoting is some way it is acceptable, but the multipuncture vial, it should not go out of your OD.
Correct. So
Yes.
that's the things about traveling. I think the difference between the other drugs and Avastin is the vial is opened in between. Why here at the most the drug vial might lose a little bit of potency, but the sterility is confirmed when we are getting eccentrics and Eylea. So that was my 2 bits. So Swapnesh, you wanted to add something?
No, so at least ETO packs is bare minimum, and the time frame for the journey, thermocol boxes with ice packs inside, and preferably try to give. Now we are getting ranibizumab at an acceptable cost. It is not as costly. So if the patient can afford, then stick to the single vial injections. If not, then ETO packs and thermocol boxes. Should we take it as a bare minimum thing which should be acceptable, or still no?
Swapnesh, one thing you should remember is that the Avastin should never be ETO'd. When you talk of ETO packs, it means that
only packs. Only packs.
Yeah, the pack has to be ETO'd,
yes.
not the syringe.
Yes.
Yeah.
So what I do is, if you see, there is when you open a glove, like say a 7 glove, I keep that 7 number glove packet and I aliquot the tuberculin syringe. I put it in that same packet, which is essentially sterile from the inside.
Yes.
I seal it and I send it with a clear-cut instructions in a cold chain, with clear-cut instructions that it has to be used within 2 hours.
Yeah, and if at all, Swapnesh, if someone is using the thermocol package, that the boxes, please check the thermocol package. If it is used for a longer time, you can see the black fungus grown into it.
Yeah, I would also like to bring to notice about the cold chain part of it, the thermocol box. We are getting many patients from a very CGHS and government empanel scheme where the drug is dispensed by the dispensary per se of their hospital. And you will not be surprised, they give you the 2 cool packs and along with it 1 injection stacked between the 2 cool packs.
And rubber band.
That's it, and they come in a 2 hours, 3 hours to you. See, seriously, I've tried to tell the Novartis people or anyone, all these people, bloody, you give them at least those pharmacies, the cool box. Patients don't understand and they walk in with the 2 cool packs in between that. So please don't do such mistakes when you are traveling and carrying. A cool packs means at least 10 to 12 bags which are adequately frozen, and then so that they can sustain for 3 hours.
Right. That brings us to whether everybody must have given a bilateral injection at some point of time. Manish sir, starting with you.
No, I have never given bilateral injections. I don't have stomach for that. I have
given at Wadia for a ROP baby, which was really not in a good shape and with aggressive ROP in both eyes. So from virtually we used to go to Wadia. So that was one instance where we had to give it because she was going to be shifted for a major surgery.
Yeah, again, Swapnesh, I will intervene in this. Why we want to give bilateral injection? Again, the same thing, why we give the Avastin. We always try to help the patients at the cost cutting issues.
Exactly. Yes.
And who suffers ultimately? I used to give bilateral several times and years together, but once I suffered bilateral endophthalmitis in a diabetic case on that Diwali day when out of station. I have to come back from my native place and operate immediately overnight. And somehow I escape in that. Since then, I have stopped using bilateral injections.
Very true. I think bilateral is a big no. It's more for a convenience of a doctor. Say you might be visiting that place, so you want to do both eyes at the same time, or it is for the convenience of the patient. But trust me, I believe, Swapnesh, even if it is an aggressive APROP, you have got definitely 12 hours. I would say that. See, we cannot justify the our own limitations of visiting the same NICU for, I know, I would be also tempted to do what you would have done, but it's worth taking. It's not worth taking that risk, I believe.
Not at all.
But driving down another 1 or 2 hours for that baby, because if you look at it, I have seen in our own city, few of the people do inject because from a single Lucentis vial they want to inject both the eyes, and trust me, even Lucentis can cause an infection. And this baby of a doctor had bilateral endophthalmitis for a so-called ROP means APROP, and he wanted to, poor guy wanted to save upon the costing of one more Lucentis. So if the single dose vials can cause such a havoc, remember Avastin is always a multi-dose vial where you can really create an havoc for that poor patient.
That also important thing is the best practices that are followed, whether OT outside. I don't think anybody in India gives it outside in the injection room or something, but for benefit of our people who are listening in, I think it would be prudent to tell our best our protocols and best practices when giving injections. Dr. Ashish, sir?
Yeah, I always give the injection in the operation theater. I put the patient on antibiotics which are given instilled about half an hour before. I don't start the antibiotics 1 or 2 days before. I still prefer to give post-op antibiotics. You ask the patient to change the way you do for your cataract surgery or for your retinal surgery. And in my case, it's just a gown. In Mumbai, I don't know how many people actually change the clothes of the patient. We just put a gown on the patient and we take the patient in. Once the patient is in, again, the eye is to be prepared with betadine the same way as you would prepare your surgical patient. Then you wash up and come and you put the speculum in. After putting the speculum, again put paracaine, and then the last drop has to be a drop of betadine. And then you give the injection. While giving the injection, you take the conjunctiva to one side and then you give the injection so that it's not in the same plane. Check the intraocular pressure. At the end, again put a drop of antibiotic and a drop of betadine. And I usually tend to pad my patient till the time they go home. Once they go home, they can remove the pad and continue the antibiotic for 3 or 4 days. That is my policy.
So dilatation versus no dilatation, and microscope or no microscope?
Always microscope. I don't think I can do anything without a microscope today.
Okay. And dilatation?
And that never struck me also, that microscope never struck me. Dilatation, well, if the patient is dilated for some other reason, if I'm seeing the patient that same day, then the patient would be dilated. But as a rule, if the patient is coming exclusively for the injection, then I wouldn't dilate the patient. I just do it without dilatation.
So Prashant, sir?
Yeah, for us, we dilate every patient before injection because I can see the movement of the needle when I am puncturing it and always under the microscope, except in a ROP babies when I am supposed to inject the baby in an ICU. I do it under indirect ophthalmoscope with a 20 diopter lens helping me in guiding the thing. Regarding the protocols, yes, it is like any other cataract surgery. For us, any patient who goes into our OT, he gets a apidine about 4 instillations for last 10-15 minutes along with xylocaine. He changes into a complete gown like every cataract. He gets a shoe cover and into his feet, because feet usually carry a lot of dust in OT. So we always insist on shoe covers now, which are disposable ones, once they come into the dressing zone of our OT. And then they are moved ahead. Inside the OT, we scrub for every injections. We scrub for every, even if I have 5 injections, my surgeon or myself, whoever is injecting, scrubs for 5 times, changes gowns, changes gloves, everything, changes whole set. So that is as rigid a protocol as we follow, because probably we have a big turnover. So we have put that habit, and now my all other team members also follow the same thing.
Preetham, sir?
Yeah. So, I give antibiotic prophylaxis for a day or two before the injection. On the day of injection, there's, the betadine is applied to when the patient comes to the clinic. The betadine is applied, and the patient is made to wait outside. Patient is taken made to wear a gown and taken inside the OT. Now, I do not use a microscope. In fact, I don't even ask my assistant to use a torchlight, because what I've seen is the microscope and the torchlight causes so much of photophobia. The patient is moving the eyes all over. I thankfully am not so presbyopic, so I can give the injection even with my naked eye. What I do is, like rightly said, put a parakin. I don't drape the eye, because what I've seen is, while draping the eye, the patient has so much discomfort. Patient is again moving his head, moving the eyes all over. The idea is to do a quick in and quick out procedure.
Yes.
So I apply the speculum. I put parakin. As a patient, I give the injection in the inferotemporal quadrant. Displace the conjunctiva always, so that the conjunctival and the scleral tract are not in conjunction. What I do is, because the patient is dilated before the injection, all the entire conjunctiva is blanched. So what I do is, at the end, just before giving the injection, I apply a parakin soaked cotton pledget at the inferotemporal site. What it does, it makes those blood vessels in the inferotemporal conjunctiva again prominent. So I'm able to avoid the conjunctival blood vessels, so that there is no subconjunctival hemorrhage. Displace the conjunctiva, give the injection, come out, put antibiotic drops. I avoid an ointment. I just put antibiotic drops, remove the speculum, and that's it. I don't patch the eye. I have seen after patching the eye, the patient has more congestion. The patient is usually calling you, even from their transport going back home. They are calling you saying that there is something happening inside the eye. So I do not patch the eye. So these are and I give an antibiotic, post injection. I give an antibiotic for at least 7 days, 2 to 3 times a day. So that's my protocol.
Manoj,
Do
sir?
you give goggles,
Yeah.
cataract goggles? If you don't,
I don't give any goggles.
In my
And
practice,
again, the most important thing, not from the infection point of view, but I ask the patient to do a little counting fingers on the table, because if the pressure has gone up, there is some ciliary artery, a transient central retinal artery pressure, then I do a paracentesis. Only if the patient is not able to count fingers and is saying everything has darkened, then I do a paracentesis. Otherwise, I do not do a paracentesis.
yes. In my practice, we have a separate operation theater for injections only, which is having laminar airflow as well as the UV lamps, and separate freeze particularly is kept for the allocated injections to keep. One more important thing apart from that, if there is no betadine drops, no injections. That is what I follow. Most important thing is that I always use the microscope. Third thing is that always see the fundus after giving the injections. If there is arterial pulsations, I always try to do the paracentesis and patch the patient. In between the transient, most of the patients are coming from outstations. If you have done the paracentesis, or if you are talking while giving the injections, most of the time organisms shed on the wound, whether it is 30 gauge needle or 26 gauge needle. It attracts the organisms there. And important thing is that I use the plate speculum, which separate the eyelashes. Your needle is touching the eyelashes, means it is carrying the organisms, mainly streptococcus or staphylococcus, which are lying there inside the eyeball. And one more important thing, as Pritham sir said, that I don't drape. I don't wash every time. Once it is washed, and every time, after one injection, I give the sterlium properly to the hands, and minimum touch or no touch technique is the most important thing here. Otherwise, all these things, if you are doing personally, you know that where you are touching or not touching. If no touch technique or to the other eyelashes or lids or anything, there is no role of drapes and everything. You are already put the betadine and drape with painted with the betadine. And post injection, we usually give the antibiotic for 7 to 8 days. That's the thing.
Yeah, one point I think is, always see the patient before the patient goes off, especially in intravitreal injection. So should always see the patient.
Yeah, that's true. That's what on table if said, if see that most of the people will show the arterial pulsations, and that itself causes the pain and transient blurring of vision. If you want to take the risk in a small crowded dish, then obviously it will land up with the iron and so many things added to this. So it is better to do the paracentesis.
And when do you call the patient back?
Can I make a comment?
Yeah,
Can I make one comment?
Yes.
Yeah. So I think this is a very, very important thing which Dr. Sasawade sir said. Avoid contact of the needle tip or the needle with the eyelashes. I think this is the most important part which he has said. The other thing is, make sure that the bare needle is not sitting on the trolley.
Correct.
I have had instances where especially, I'll not name the hospital, the corporate hospital where I go to. Sometimes a new sister is there, but the new sister, I've loaded the Avastin, and she's merrily uncapped the needle and kept it on the sterile green towel on the trolley. And I asked her that, why did you uncap the needle? The bare needle is lying on the green drape. So she said, no, but this is how we give the subconjunctival injections after cataract. So there may be other people may be following some other patterns, but the bare needle should not touch anything. Once it comes out of your vial, it should be capped. The next time it should be uncapped is when you're giving the injection without contact with the eyelashes.
Yeah, that's true.
Why are you using the same needle? Normally, what I do is use one needle to take it out.
Yeah. No, it's a separate needle. Yeah. It's a 26 number needle, because the tuberculin has a 26 number needle that is being used to withdraw.
And 30 gauge.
And a 30 gauge, but that 30 gauge needle is capped, and I uncap it myself before giving it. The sister, some sisters or staff have a habit. They are doing it to help you. They are uncapping it and keeping it on the trolley and then giving it in your hand, which should be avoided according to me.
When do you call the patient? That's the next point for follow-up. Sasawade, sir?
Yeah, follow-up depends upon what is the initial condition, basically, for what you are given, and patient general condition. If he is having uncontrolled diabetes, DKD, and these risk factors are there, then we call early. Early means within 48 hours. If it is outstation patient and I feel there is hardly any risk of infection and it is well controlled for BRVO, CRVO cases or ARMD cases, then straightway I call after 1 month, provided we give the instructions of pain, redness, watering. If there is there, then obviously he should report early.
Dr. Bhavan,
so for us, the protocols are very rigid. We do see the patient after and on the next day. That's for sure. And that too, a dilated fundus as well as a slit lamp. That's a protocol at our place, and then a month later.
So, in case patient is outstation, do you call somebody referring surgeon?
We expect the anti-segment surgeon to do the same for us.
Okay. Ashish, sir?
Yeah, the first time the patient receives an injection, I always call the patient on the next day.
Right.
The subsequent injections, I may decide to call, depending on where the patient is. I may not call the patient on the next day. Sometimes might call him up to 15 days or a month later. But the first injection, always next day. Because that's the time when, once you and the patient understand how he is going to behave, then it becomes a little bit more predictable.
Okay. Dr. Preetham?
So, I won't really see the patient on the next day. Usually a call goes from my clinic 24 hours later to ask the patient how the patient is doing. whether the patient's vision whether it has drastically dropped or not. So, my staff are sort of tuned to ask the patient how the patient is doing. We always expect sometimes subconjunctival hemorrhage, but with little bit of triage questioning, you're able to understand that the patient is doing fine. So this is what I do. I usually, after the first injection, the patient is called after 2 weeks, not more for the infection part, but just to tell the patient, how the injection is working. Showing the patient an OCT 2 weeks later goes a lot in building up the confidence of the patient in the therapy that we are offering. So that is why after the first injection, I call the patient after 2 weeks for that aspect.
Yeah.
After that, after the second and third injections, I do not see the patient. Patient states come for the second injection, the third injection, and then the treat and extend of the PRN protocol.
Yeah.
I
So,
personally feel it's extremely difficult for patients to keep coming again to the clinic so often.
yeah, I'll just add my personal experience because all these injections are monoclonal antibodies. One of my patients for whom I had given one of the approved medicines, approved drugs, the newer ones, I had given a bilateral injection 4 days apart in first month, and in second month after giving loading dose for the first eye, that patient came back with inflammation, which the patient wasn't really aware. It wasn't really an angry looking eye, but the patient had drop in vision, which he did not realize because he had advanced AMD in that eye. But I could make out and I could pick it up because the patient was coming for routine evaluation. So that's something I wanted to share, that it might happen even after in subsequent injection as well, since there is an immune response might be there.
Yeah, so I think what is important here is, the patient should go back with certain warning signals which are sort of highlighted to the patient, that if you have any pain in the eye, if you have further loss of vision in the next 24 to 48 hours, or if you have any kind of a swelling, then you should report immediately. I think this should be driven home, at least after the first injection, or after every injection, from the infection point of view.
Okay. Dr. Preetham brought out point that he does OCT after 2 weeks, but that's my next question to the panelist. Do you repeat the OCT before each injection? Do you clinically see the patient before each injection, or the patient comes to OT, you finish the loading dose and then see the patient is evaluated after 3 months? What is followed by everybody?
So I'll go first.
Yeah, please.
Yeah, so it is very reassuring for the patient for me to wear an indirect ophthalmoscope, look at the fundus, and reassure him that his treatment is on the right track. See, it's without prejudice, I check the vision at every visit. So it is scientifically proving to the patient that, look, your treatment is on course, and it is very reassuring to the patient and the relatives that you see the patient. If you straight away usher the patient into the OT, many a times the patient has many questions, and then it becomes, your patient doctor relationship sometimes becomes a little, it gets affected.
Okay, what about OCT?
No, I don't do an OCT every visit.
Okay.
Because I've told them that after the 3 loading doses, I'll be doing the OCT again. So just a simple clinical examination and a vision at least is done.
Prashant sir?
For us, what we do believe in seeing every patient at a month before injecting. At that time, vision is done, slit lamp evaluation is done, fundus is done with the indirect and slit lamp biomicroscopy. If it is a case of AMD, where we have planned to do a 3 loading dosages of injection, then I'm not going to repeat those. But if it is a case of a diabetic macular edema where we don't do a loading dose or concept of it, there I might do an OCT if I feel clinically it is not responding. And so OCT guided further injections is the way to treat it. But if you're planning a loading dose, and especially in a case of AMD, you don't need to. Now, why do you need to see on a slit lamp? Not uncommon is a patient times when you suddenly see for the second time, you see there is some inferior fornical congestion, or some calastae or a chalazion patient is harboring. So these things, if you miss upon and if you inject in that eye, you might introduce an infection and cause unnecessary problems. So it's also, and as very rightly said by Preetham, that we need to speak out to the patient. See, these are low prognosis category of patients. Here they need continuous counseling. And unless if you lose that contact between the patient and you, patients are not going to understand what you are trying to do them.
Right.
Yeah.
Manoj, sir?
Yeah. Apart from this one, we check every patient's vision every time, slit lamp examination, fundus evaluation. Even we take the fundus photograph. Now the questions comes every time, OCT or not OCT. Why these questions comes? This is again the question of money. And every time patient feels that doctor is extracting every time. My straightway say to the patient is, if you have money or not, doesn't matter. But if someone is asking you to examine yourself, it is for you. You should say that some God is checking you and taking care of you every time. Otherwise, what is there? Why every time I will do the say OCT? If someone is advising, means someone is taking more care for you. That is the thing one should pass on the message to the patient, and it gives several examinations, gives you several clues as well as the hints for the surgeon also to, when to give the injection, when to prolong the interval between the injection, and the clinical scenario of each patient is different, and without OCT it is not possible. Even though we are following 3 injection, 4 injection loading, unloading doses, but what about on real field where every patient behaves differently? Right. And that's why OCT is must every time, and you should convince the patient that it is required, and that's why we get it done every time.
Ashish, sir?
Yeah, I do not do OCT every time. But if the patient feels that he's had a abnormal outcome, like sometimes some patients say that, you're given the injection, but my vision is not, or I'm worse off. So in that case, definitely I would do a OCT in between. If I've thought of giving the 3 loading doses, for most patients, I would not do the OCT in between. Again, some of the other patients, they want to see the OCT. The patient insists that the OCT to be done. In such cases, again, we do the OCT.
All right. Dr. Swapnesh, I think you have anything that you would like to ask?
I think last thing that we should cover is the insurance part.
Yeah.
How does everybody ensure that in today's era, when we have that IRDA letter with us, which has said that after, I think, 1st of October 2020, intravitreal injections should be covered under all the new renewals of mediclaims and new mediclaims, both mediclaims which have been renewed as well as newly issued. So how does the panel help out the patient with their insurance? Any guidelines so that it can help to improve the compliance?
See, for us, if I begin it, what we do is we tell them now, according to this, since October 2020, you are eligible to get an insurance claim for it. So what you should do is we give them a ruling of that particular thing, whoever patient, and we tell them if they have any problem for the first injection, we tell them you need to pursue after them because you are after getting money. No one wants to give money easily. So you have to, in fact, incite the patient to fight against the people, against the insurance company, and ask them to and provoke them to go ahead with doing a writing work. So if everything is done in writing, most of the patients are getting now slowly their money back. So you have to actually tell them, you jaake jhagda karo, write it, do it in writing. That's it.
Sir, Vaidya sir,
Yeah.
sir,
In my practice, there are 2 issues. What injections you are giving. If you are giving Avastin, obviously you are a doctor, you are not supposed to sell any medicine. You are not a pharmacy person. That itself is illegal. One thing is that you are doing off-label job, and on the top you are giving in writing the bills of these things. So particularly Avastin, we try to avoid the bills to the patient, whether he is using for any purpose, not at all. Other things are there for the Avastin, this one, Accentris, Fusentis, or even Eylea. They are purchasing from the pharmacy. What we have to give is that in admission, daycare admissions and all those things, we hand over it to the patient, and now it's his job whether it is to be claimed or not to be claimed. But obviously cashless we don't do for the injections.
So I think this is a very important point which Dr. Sasade sir has brought, because when we are first counseling the patient, it's very important. I always ask the patient whether he has insurance or not, and if the patient has an insurance, then I usually counsel the patient for
Single wide.
the FDA approved agents and not the off label use, because I tell the patient that with off label use it is possible that your insurance may be rejected. So there only the distinction happens. And what Dr. Bhavan sir said is absolutely right. You have to, I actually give a printout of the IRDA
Same here.
guidelines of October 2020. My staff has made, I don't know, thousands, hundreds and thousands of printouts of that to give it to every patient, and with it goes with the Mediclaim papers. That printout goes, and the patient is told that if there is any problem, you tell us, and you have to write. You have to write, keep writing to the insurance authorities.
Also, to add to it, many of these companies have come out with patient schemes. So once, not maybe the first visit, but once the patient is with us, we can sit with them, and if the insurance is getting passed, like ILIA has a certain kind of a patient program, Acentrix has a patient program. So if every VR surgeon is aware of them to pass on the benefit, I think that is going to improve the compliance. Like Acentrix also
but I think Sapnesh, that the companies are going at lengths to make every VR surgeon and anterior segment is aware of those programs.
Yes.
I don't think we need to do anything more about that.
Sure.
That's a part of the marketing.
Yes. So I think the last 3-4 rapid fire questions are there, and then we can conclude this very interesting session. So I would just ask the drug of choices. I'm sure these are very simple questions for the expert panelists, but just because there are a lot of general ophthalmologists also who are watching this webinar. So the drug of choice of any two can answer and then pass on. Drug of choice of anti-VEGF in a case of DME or AMD with a history of recent MI, recent CVA, recent cerebrovascular accident. Anybody?
Lucentis or ILIA. That's it.
No, drug of choice when there is a recent MI.
Yeah, Lucentis or Acentrix and this.
Okay.
See, in AMD, there's no choice. You have to use either Acentrix or ILIA. When you use Acentrix, it's sometimes better to use a little lower dose of 0.3 instead of 0.5. But for DME, we always have a choice of Ozurdex. So you can use Ozurdex in these patients.
So I'll answer this differently. I'll not use the brand name. I'll say ranibizumab or aflibercept. Avoid bevacizumab.
Okay,
that's true. That's correct.
Yeah. A patient who is a pregnant lady diagnosed having diabetes and coming to you with a CSME. So, and coming to you one at 6 months of pregnancy and one at towards 8.5 months of pregnancy. So 2 scenarios in this.
And one of the scenarios that I have faced is a pregnant lady in the second trimester having myopic CNVM in only eye. So that was a tricky situation. So I think that's a pertinent question.
So 3 questions.
I think there is hardly anything. There is nothing is proved basically, but the caution is there. And when this is a precious issue, who will take the risk? Yeah, I can advise the Lucentis to everyone, but how to answer that this Lucentis is not going to do any teratogenesis? Then all the onus comes to you, and you don't have any evidence in the literature to say that whether they also mention caution, not advisable in pregnancy. That means it is against the advice, whether it is 3 months, 6 months, or 9 months also. People will again take their defensive stand. And same thing I do most of the time.
I think Ozurdex can be a safer option or a laser.
No.
Why do we forget that?
Extrafoveal AMD definitely laser.
Yes. But the Ozurdex itself, if it is causing the secondary glaucoma and if she is 8 months, 9 months, how will you manage that?
No,
that is more riskier than this one. And young patients are going to develop secondary glaucomas invariably. after steroids.
What I would tell you about, leave aside that, we are more concerned about the systemic part of it rather than at this point. So if you look at systemic safety after first trimester, steroids can be used. Regarding the use, secondary complications to the eye in the form of cataractogenesis and glaucomagenesis, well, 1/3 of the patients can have, but that is not going to affect the baby. And a one-eyed female who is so desperate to have a baby, I think she will be happily accepting that part.
Yeah.
And I think if I have to use an anti-VEGF, I would go for the research molecule of ranibizumab.
Yeah,
because it has minimum protein binding capacity, and which is, I think, just few hours. They have said they say it's just couple of like 24 hours or 48 hours. So I would probably use that.
Yeah, the basic is that the drug amount is going so less, it is hardly going to cause anything. But obviously, the patient should be qualified enough to understand the things which we are doing for the betterment of them. Then it is possible with special consent. Otherwise, something goes wrong because of some another causes also. The blame will be towards the vitreoretinal.
Absolutely.
In a post-vitrectomized eye and a situation of a diabetic macular edema, we all know that the expiry of the drug within the vitreous cavity is even more faster now. So I want the opinions that is everybody shifting to Ozurdex in a post-vitrectomized eyes for DME, or still is there a role of giving anti-VEGF, and is there any role of giving anti-VEGF at a smaller time period, like because the T half of the drug is even faster? So does anybody give 2 monthly anti-VEGFs so in a post-vitrectomized eyes and a setting of recurrent DME?
You mean 2 weekly, not 2 months?
2 weekly. 2 weekly. Sorry, 2 weekly.
I think, Swapnesh, all things are correct and possible and are doing very routinely. First thing is that you have to see that why the DME is persistent despite of vitrectomy. If there is a ERM, or whether it is an insult of surgical insult itself has caused, like cataract in a diabetes can cause cystoid macular edema. All this responds well to the steroids. You can give even subtenance in a vitrectomy. It is well absorbed through the sclera and enough to manage these types of cases for months together. And within a month, if it is cured, that means it was a post-operative cystoid macular edema, nothing to do with the diabetic microangiopathy. If it is along with the microangiopathy, then anti-VEGFs are required, and the frequency you can decide according to the systemic control as well as the local control.
Okay. Anybody to add something?
I'll give a different twist to this.
Yes.
So if in a diabetic patient in vitrectomy, most of my diabetic vits are accompanied by phaco and IOL. So you have a pseudophakic patient. So then why are you worried about? I mean, most of these patients post diabetic vits who are pseudophakics, I am banging the edema with steroid. So so if you're anyway giving steroid, I mean, whether you give it intravitreal or like Sasadoy subtenance, I think it's a no-brainer.
Yeah, most of the time I give at the conclusion 2 drops of IVTA inside and close the case.
Yeah, absolutely. So you're safe for at least another 6 to 8 weeks.
Yeah.
So I think that ends the list of questions, and we are almost on time.
There's one thing I want to raise.
Yes, sir.
Yesterday, I saw a patient. 2 days ago, I saw a patient. Patient had vitreous hemorrhage 1 month ago. Anterior segment surgeon saw the patient, and did a OCT. There was no macular edema. There was no sign of proliferation, and the patient was injected with anti-VEGF for vitreous hemorrhage. When I saw the patient 3 weeks later, patient had a large retinal tear superotemporally, and the tear was crossing over the blood vessel, and that was the reason for the vitreous hemorrhage. And the patient had a detachment which was threatening the macula. So I think the most important thing.
ये retinal surgeon की घर-घर की कहानी है.
No, that's not the most important thing. Is that when you give an anti-VEGF, you have to be sure of the indication. A vitreous hemorrhage without proliferation is not an indication for anti-VEGF. A macular hole is not an indication for anti-VEGF. Neither is an epiretinal membrane. So these three things, even if they may cause decrease in vision or seem like they will benefit by anti-VEGF, are not indications for anti-VEGF injections.
Yeah, that's true.
So Ashish, this point is for Dr. Parikshit Gokte to have another webinar on indications of anti-VEGF.
No, I was coming to that Parikshit sir said that slowly all the geos are going to give intravitreals in the near future. So
yeah, that's true.
Yeah, true. So
I think closing remarks by Manish sir and then followed by Ragini madam and Parikshit sir if he is around.
Yeah. So I think it was a wonderful discussion. We have covered lots of aspects of intravitreal injections, since a lot of our anterior segment colleagues are probably giving injections already. It's very important to keep all these key points in mind when we are giving injections. As Dr. Parikshit said in his opening remarks, that probably we will be doing more injections than cataract surgeries in near future, if it is not already happening. So I think the safety of the patient, safety of your own self, and avoiding avoidable complications is something that every person, whoever is planning or already injecting the patients with intravitreal injections, is important. And it is also important to, as the last point that Dr. Ashish sir made, that don't inject because you see something which is different from normal retina. Make sure that there is an actual indication to give the injection, and then only go ahead and give, because it is a potentially dangerous procedure, even if it is a quick and simple to look at. It's a potentially dangerous procedure with medico-legal consequences that can have far-reaching effects on your practice. So with that, I think that would be the take-home message from this particular webinar that we have had today. Thank you.
Ragini madam? Ashish sir, please. Sir has raised his hand. Ragini madam.
Thank you so much. I think it was really a wonderful webinar. We didn't expect the series to take off so well, and I think that all of you are very experienced and very practical surgeons, always taking care of the patients, and all the points that you have all put forward, all the 6 of you, are very, very pertinent. And what I can glean from your discussion is that the patient is the center of our universe. And he remains a priority, or he or she remains a priority always. And what you rightly said, and like Parikshit said, that, everybody is giving intravitreal injections. It is not restricted only to the retinal surgeons. And that is why it was very important to know when, which, how, and really when it should be used. It was a very, very fruitful discussion. Thank you, Manish and Swapnesh, for hosting it. Thank you, a big thank you to all the experts, Dr. Manoj Sasavde, Dr. Ashish Vaidya, Dr. Preetam Bhavan, and Prashant Bhawankule. Preetam Bhawankule ho gaya. Thank you, Pankaj, Sirish, and a big thank you to Parikshit Bhai. So, this series was started by Sir, what will you do was what he had named it. And I think it actually means this is what we are doing. So I think since we are Sir's chelas, we continued this series. And Swapnesh is one big chela. I think, Swapnesh, your ideas are a big hit.
No, Madam, I agree. Madam, if I may, I'll just make a comment. The whole idea of Sir was, the whole idea which Sir mooted with what will you do was to bring evidence-based medicine to bedside. That is the whole point here.
That's good.
Very true. And what I feel is that all of you are placed in different parts of Maharashtra. You all have very big practices. You all are attached to institutes. You all have come up the hard way, but you all are teaching the right thing to the budding retina surgeons or ophthalmologists, that, the patient comes first, which is a very, very important take-home message. It's very easy to take shortcuts in life and suffer, like Manish said, that, there are a lot of medico-legal implications. And like Ashish was saying that, how can you just have a vitreous hemorrhage and inject? And we've been also seeing, and I know Lane sir would call up that person and say that please don't do such things, without involving the patient in all these things. But I think it has been a wonderful, wonderful webinar. Thank you so much, all of you, for your time and patience. And we shall continue the Retina series. And please, any more inputs or anything else, and maybe we can continue this in our MOS conference also. Everybody, all of you. Thank you so much for a lovely webinar. And Antor, thank you so much for hosting it. Sirish, Pankaj.
And now Dr. Parikshit.
Parikshit, sir. I think he has a lot of meetings with the AIO Scientific Committee, so he's always busy. So, Sirish, me, Pankaj, we are all cataract surgeons. And it has been an eye-opener for us. And I think since we are all very senior, not to say that the junior crowd is not good, they are very good. But I think we do understand this point. And if some of them don't, they will in the near future. That what we are talking about makes practical sense. Sirish?
Yes, ma'am.
Would you say something and then give a vote of thanks?
Yeah, before Sirish, I will talk. Sirish, wait. This was the most vibrant discussion today I have observed. Giving a talk on and seeing slides and giving a talk on one topic and closing your things. Apart from that, this type of discussions are more potential and creates more awareness amongst all of us. Everyone is at the tip of the toe. What patients will come, what is his opinion, what your knowledge keeps on talking here. Your experience keeps on talking, and where you stand actually amongst all six also matters, and all these MOS people are observing you. So I think thanks to this basic idea to the MOS that you have brought together to all of us and created such discussion in the web series. And I wish that there should be many more such types of webinars, which includes only discussions. And it gives a lots of messages than an expert talk.
Yes, Dada, I agree completely with you. Like we said, sir started this and Swapnesh was very keen on this. And in fact, this is the reason why what you pointed out. I mean, I would never say that you are, in these webinars, all the videos are on. Whereas if you see in other webinars, only the speaker's video is on and so many videos are off. So that is one point, that everybody is actively and interactively involved. And the second thing, like you said, the main thing is that all of you are practicing and you all are putting out practical points and discussing them out in detail rather than one person talking. And one more thing that Swapnesh noted was that, see, if I have to call you up and tell you, Manoj Dada, please come for the webinar, it's very easy for you because you don't have to sit and make a presentation for one day with busy practices, busy medical colleges and the COVID times. And you don't have to think about it because you're doing it daily. So there's not much of revision or preparation involved. And it's really active. It keeps everybody on the toes, not only you, but everybody. And thank you so much for appreciating this format. And I think Preetham and Sirish and Swapnesh and Prashant Bhai and Manoj Dada, everybody, all of you, Ashish Bhai, I think this format, at least for as MOS and BOA is there, I think it is here to stay.
And one more thing, madam, you just started with the SN alumni, but now you just say that I am in Marathwada, Prashant is in Vidarbha, Preetham and Swapnesh, even Ashish sir in Mumbai, and Manish is. But the practice pattern is much different. Our opinions differ and we express it very frankly.
That's exactly the point of the whole thing, because, supposing when I'm at Anandvan and if I'm doing a particular thing, so place does matter. The practice does matter. People do matter, because supposing when a patient comes to you and he cannot afford a 40,000 injection, whereas a person coming to Preetham will definitely afford a 40,000. There are some practical points in life which we have to, or say Ashish practices at Mahim. Things are going to be different. Opinions are going to be different. You have to make the best of the circumstances that you are in and give the best to the patient. The science will never change. You will do the best for the patient. That is the bottom line. But some things may differ. Like say, for example, when I am operating at Baba Amte's Anandvan, I cannot do phaco in a subluxated cataract with pseudo exfoliation or a hypermature cataract. Whereas if I'm in JJ, I'm doing phaco emulsification. So things are different. So I'm sure in retina, things are different too. But what I wanted to actually point out when I was saying was that different places, different surgeons, different point of views, and you need not agree on everything. That's the point of the whole discussion, that the people from Marathwada will benefit from your input. So it's wonderful. I mean, there are so many negatives to this not meeting each other, but a lot of positives to these online platforms. Lots of positives.
Lots of positives.
Experience count.
Thank you.
Finally, it is the experience counts.
And patient taught us a lot.
Definitely, Sirish. Experience does count a lot.
Yes,
Definitely.
And
we've all been kicked. All our hair has gone grey, and that experience has helped us grow.
Yes, that's true.
And patients are best teachers. They taught us a lot.
Yeah.
Very true, Sirish.
Very true.
Madam, Manoj and Prashant are my retina teachers. Manoj used to give me for 20.
We all learn a lot from you.
So we learn from each other. We learn from each other.
I learned practice, how to do the practice.
We are very poor in retina, and we must blame Preetham for it, because Preetham has been with us and established the retina department of JJ, and now we are doing, the lists are very big every day. So if we don't know retina, we must blame Preetham for being the best.
Yeah. I learned a lot from Sirish practice pattern. Lots of patients seeing but remaining calm and quiet at the end of the day. He never shouted on anyone. That is what I have.
He's very quiet. He's very calm. He's very calm.
Great. Thank you very much, Sirish.
Thank you,
Sirish.
So, vote of thanks you have proposed?
Yes, Dada.
Yes, madam. Yes.
Raman bhai wants to share his video before that.
Yes. Pankaj, we forgot. Actually, you SMS us. We forgot. We are ragging you up, Pankaj, actually.
Raman bhai.
Sorry, Raman Dada. Please go ahead.
Thank you so much, ma'am. I will just share a screen for the 2 to 3 minutes. As you may be aware about, this webinar is supported by Entered Pharmaceutical, and Entered Pharmaceutical currently has 170 plus ophthalmic and ENT product portfolio in their baskets. And this week is that the whole nation are celebrating as the National Eye Donation Fortnight Week. It's observed every year from the 25th August to 8th September, and it's a campaign which aims to create the mass public awareness about the importance of the eye donation and to motivate the people to pledge their eye for the donation after the death. Here, I would like to take an opportunity to show the recently DCJ approved Phenomen Plus video. And for PRK, we have, like you said, so much to all the medical fraternity for making the NTOD as India's fastest growing ophthalmic and ENT company in the current era. And thank you so much to all the ophthalmologists. Thank you so much, ma'am. Over to you, Shiri sir.
Yes, thank you, Mike. Overall, it was a very wonderful and useful webinar. And on behalf of Team MOS, I would like to thank our own speakers, Dr. Prashant Bawanpure, Dr. Ashish Vaidya sir, Dr. Manoj Saswade sir, and Dr. Pritam Samant for sparing their valuable time and giving all valuable tips on this much needed topic. Our host, Dr. Manish Bapaye, Dr. Sapnesh Rawant, have framed and conducted these webinars so well. In all, I can proudly say that all 6 of them are star of Maharashtra, having quality practice with the state of instrumentation and institute and are icon in their region. MOS is proud to have member like you all, sir. I'd definitely like to thank our President, Dr. Parikshit sir, Scientific Committee Chairman, Dr. Ragini Madam in particular, who brought all these scientific stuff for every member. My friend and dynamic treasurer, Dr. Pankaj Shah, for all the help. And I would like to thank NTOD for their technical support and all the delegates for active participation. Thank you. Thank you all.
Thank you very much.
Thank you. Thank you.
Thank you, everybody. Thank you.
Thank you.
Thank you.
Thank you
Well
for
done,
opportunity,
Swapnesh.
madam.
Thank you.
Thank you.
Great
Thank you,
job,
Swapnesh.
Thank you.
Parikshit, Dr. Ragini, Sapnesh, Manish.
Sir, Sunday la betu.
Yes.
Sunday la betu.
Yes, I did.
Okay.
जे जे आहे ना गुरुकुल